This was an observational study where we collaborated with researchers at Duke, Hokkaido in Japan, and Regensburg in Germany to collect over 8,000 samples from 1,300 patients undergoing allogeneic stem cell transplantation. And the objective was to understand how the composition of the gut flora, in particular diversity, influences the risk of patient outcomes after transplant. And the bottom line of what we found in this abstract that we're reporting today is that the diversity of the gut community pre-transplant predicts long-term survival. So specifically, patients with low diversity samples have worse overall survival. And this is largely explained by transplant-related mortality. So there were 4 centers in the observational study. The majority, and we had 1,300 patients across all 4 sites. 80% of the patients came from Memorial Sloan Kettering because we've been collecting since 2009. The other 3 centers have been collecting at different time points more recently, and they comprise the other 20% of the patients. And we collected essentially weekly samples from all patients, although we also have another project at MSK with more dense sampling that's embedded in this as well. In this observational study, our primary endpoint that we defined was overall survival, but then in transplant, the drivers of mortality are relapse, graft versus host disease, infection, and organ toxicity. And for analysis purposes, we usually group the last 3 under the umbrella transplant-related mortality versus relapse-related mortality. And in this study, over and over again, we saw that an injured gut microbiome drove transplant-related mortality. And by the way, specifically, when we were able to do a subset analysis in patients who got T-replete grafts as opposed to T-depleted grafts, we saw that it was actually explained best by graft versus host disease as the most important endpoint. So the results that we're presenting at ASH this year is not only does the diversity at the peri-neutrophil engraftment time point matter, but that the diversity at the pre-transplant time point matters to predict patient outcome. And the reason that's important is that pre-transplant, we ordinarily in routine clinical care do a lot of health assessments of the patient. We assess heart function, liver function, kidney function, lungs, and so on. Well, the microbiome is really the forgotten organ, and we'd like to move toward an era where we also assess the health of the microbiome before transplant. And that might allow us to do several things. One is it might allow us to intervene with some remediation or preventative strategy that's targeted at the gut community. Or perhaps it might inform other strategies. For instance, how intensely should we prophylax a patient for graft versus host disease? Perhaps the microbiome could give us a hint and allow us to tailor medications to each patient's own ecosystem. Nothing in our study recommends a practice change at this point because it's a retrospective observational study, albeit a multicenter one that has validation cohorts built in. What it really allows us to do is now to embark and continue on randomized clinical trials that can really inform practice change. So for example, we have an ongoing randomized prospective clinical trial at MSK where we randomize patients who get fever and neutropenia after transplant to one of 2 different antibiotic regimens, with the idea that both are safe enough to prevent bloodstream infections or treat bloodstream infections, but one is sparing of good bacteria in the gut and the other may be harmful to them. So in terms of frontline practitioners, we get a lot of interest in trials like this. I think that people are ready to start thinking about the microbiome, but at this point we're still in the realm of clinical trials and not yet routine clinical guidelines.